back. We're going to do HQ challenge number 19 today, dealing with a little bit of IS therapy, hyperexpansion therapy. So which of the following would be contraindicated for SMI therapy? So on your MBRC exams, they may not say incentive spirometry or IS therapy. They may say something about SMI therapy or the SMI maneuver. SMI stands for sustained maximal inspiration. And if you think about it, when you instruct for an IS, you're having the patient take a slow, deep breath, that's maximal inspiration, and then you're having them hold it, which is where that sustained comes from. So a sustained maximum inspiration IS therapy. So a contraindication would be reasons that we don't do it. Well, obviously, if a person cannot do an IS therapy because they're unable to follow commands or they're unable to understand the instructions, you wouldn't do it. But also a contraindication is if they cannot take a good deep breath. If they can't take a deep breath, this isn't going to be very effective. So the quantifiers would be inspiratory capacity. If the inspiratory capacity is less than 33% of predicted, or if their vital capacity is less than 10 mLs per kilogram of ideal body weight. So let's look here. So we said an IC of less than 33. Well, this is an IC of greater than 33. It's not that one. A vital capacity of 20 mLs per kilo. That's pretty good, so it's not that one. An IC of 2.9 liters, that's 2,900 milliliters. That's a pretty good inspiratory capacity. So what's left over is a vital capacity of 600. So I'm just going to say, even though we don't have this patient's height to calculate ideal body weight, if a vital capacity is typically less than 1,000, you need to start thinking about some type of hyperinflation therapy or some form of positive pressure therapy. All right, second question, which of the following shows improvement of that atelectasis? So as we've been doing SMI therapy or IS therapy over a few days, how do you know the atelectasis is getting better? All right, so just looking at this from a test-taking standpoint, we've got an increased opacity on the chest x-ray or a decreased opacity in the chest x-ray. So it stands to reason the answer is going to be one of those because they're so very similar. So let's leave those just a few minutes and make sure, okay, there shouldn't be a tracheal deviation. If you're clearing up atelectasis, if there was a tracheal deviation present, like if it had been deviated toward the affected area, technically, as you recruit those alveoli, you should have that trachea becoming more midline. So a tracheal deviation is not it. Bronchial breath sounds. Well, atelectasis can cause bronchial breath sounds when that area gets really collapsed and very dense, but as those alveoli are opening up, you shouldn't have bronchial breath sounds anymore. So now let's talk about the term opacity. If something is opaque, you cannot see through it. It means it's dense, it's more solid, and it shows up white on the chest x-ray. All right, so if we're treating the atelectasis that is normally very opaque on the chest x-ray, it shows up as a whiteness on the chest x-ray. As it improves, you're going to have a decrease in the opacity. Okay, it's going to become less white, more gray as you recruit and have more air in those alveoli. Hope this has helped. See you soon.